this concludes our presentation for today with this panel. So we are kindly inviting all the participants to post their question via chat. After hearing such interesting presentation in regard to lung cancer care needs, I'm positive that we'll have received many questions from the audience. Before that, I want to let you know that Anne Maurice and myself declarations of intents are available online. So let's start the Q&A session with Deborah, who will summarize for us the missing 2 slides from her presentation, missing due to some technical difficulties. Please be advised that you will find all presentation in the webcast as well as our discussion.
Thank you very much, Elena. Yes, the last 2 final points I wanted to make around the unmet needs was, well, the first one was around clinicians not forgetting that they've got patients sat in front of them who, the majority of clinicians do an excellent job and are very empathetic, and that's fantastic to know. However, it isn't universal, and so there is a need to flag this. We have stories of patients, and more than one, reporting that their oncologist doesn't even look them in the eye when or look at them when they're giving results. Now that's very disconcerting, and it doesn't give patients the feeling of trust that their oncologist has their best interests at heart. One of the other areas is that obviously for ALK positive patients specifically, it's a very positive diagnosis in the field of lung cancer. Let's put it into perspective. But some oncologists have been given patients their diagnosis and almost come across as excited. And I think in the early days that needs to be tempered with acknowledgement that the patient has just heard that they've been diagnosed with lung cancer. And they might be in a different place to the oncologist who's thinking, but this is good news, it's ALK positive, which it is. But it's just that there's a real need for oncologists for some additional skills training, I think, in some areas, maybe with the junior doctors around, how to communicate with patients. So that was the one key area that we feel there is an unmet need. And finally, we know that patients go to different size hospitals across the UK, and you can't expect all oncologists to be experts in all areas of lung cancer. So we just feel that, so again, looking at the results of our survey, feel that there is a bit of a need for maybe a more of a partnering system with oncologists in smaller centres, matching up with oncologists in the centres of excellence, maybe a buddying system or, peer-to-peer, because then that will again lend itself to there being a consistency of care and management of all lung cancer patients, irrespective of the size of the hospital that they're being treated at. So those were the 2 points that I was unfortunately not able to get across. So thank you very much, Lena, for that opportunity.
You're welcome, Deborah, and I'm taking the liberty to ask the first question. From patient advocate to patient advocate first, and after that from patient advocate to doctor. Deborah, I kindly ask you to tell me if it's possible the average time for a lung cancer patient to be diagnosed. And this is the main problem in my country, and that's why I wanted to know if you have the same problem.
Yes, we do. I think it depends on when you take the start point. So so the work that we've done is we've looked at the start point being a patient having the first symptoms and visiting their first clinician, and in our case GPs or primary care physician. And so if you look at that as the first time point in time, in some instances, it's very quick. It can be as quick as 2 to 4 weeks. We've had members who have been diagnosed, but we've also got members where it's taken up to 18 months. And I think one of the challenges is if you present to your GP and you don't have a history of smoking or family history of cancer, it isn't the first thing that GPs think about, and so it results in patients being prescribed other treatments for maybe asthma or heartburn, and that delays treatment because very often they present with a cough, and that cough doesn't go away. But again, from a patient's perspective, if they've been given a treatment by the doctor and it didn't work and it's a cough, very often they wait before they re-present to tell the doctor that it hasn't worked. So there's a delay in every single step of that process if patients aren't considered as there being a possibility of it being lung cancer right from the start. And so that delay system gets worse and worse as you go further down that pathway. And again, for the gene mutations for patients in secondary care, again, it's very important that they are diagnosed quite quickly. But we see a disparity in time that can take as well in the UK. So at the moment, it's very hit and miss, I would say.
Thank you very much. And I just want to wrap up this question with Anna. How can we optimize this patient pathway through diagnosis and later on treatment? Thank you very much.
I think, as Deborah mentioned, I think we need to focus also on GP education and patient education. So it's a two-pronged approach. So getting both of them to become aware. We have sort of certain referral systems here anyway, a 2-week rule. If you have a cough for 6 weeks, you're supposed to present to your GP. But a lot of the times the patients don't. So I think starting with the primary care, focus education there, and then hopefully it will trickle with the addition of a screening program, which I know will come. Then we'll be able to sort of capture those early diagnoses, treat them curatively, and our stats will improve.
Yeah, that's great discussion.
Thank you very much.
Yeah, great discussion, Anna and Deborah. Thank you so much for that. So we've just checked in the question box and there's no questions there currently. So I will take the liberty of asking the next question. So Mia, your talk on really the impact and the need for psychosocial support, of course, is something that hits home to a lot of people impacted by lung cancer. And I'm just wondering, in your experience, how do you feel we could best integrate this into the care pathway so that anyone who needs it can access it in a timely fashion?
Well, I think there are a lot of steps to take before we can include it in the health plan as we would like to have it included. But you could do small steps because these interventions, they do exist, even if they're not incorporated in the healthcare system really, and there are no connection. They're not coordinated in any sense that I have seen, not in my country and many others. Some countries do have another system, so that much I understand. But you just need to, I think you have to open up and, form teams, add members to the teams. First, when I came to the hospital, even I'm myself a psychologist, but I really saw that there was a need for psychologists, not only for the patients, but also actually for the healthcare professionals along the way. So I really think you should broaden the expert panel in the hospitals. But the first thing I think that is most important of all these interventions is for lung cancer patients and every cancer patient maybe is to include physical activity from the beginning at diagnosis. How are you going to do this? How are you going to help the patient with this? Because this is whatever treatment you get, you need the physical activity. if I can take just a short personal example, I had a bike accident right after my treatments, which led me to an orthopedic what do you call it?
Problem.
No, I hurt my arm, and so I came to this facility, orthopedic facility, and there I got all the help for my shoulder that I needed for my cancer. So that was just an eye opener for me, and I think these facilities should be incorporated for cancer patients.
Yeah, you make such a great point there, because really we have to start and do something. And as you say, if we can build on the small interventions and make a larger program, it's going to be something that's going to have a really positive impact. So Shani, I'd like to ask you the next question, if that's okay. I mean, huge congratulations on all the work that you've been driving in Israel. It's really fantastic and amazing to see all of the things that can happen, can occur. So in terms of lung cancer screening, from your experience and it trying to get something introduced in Israel, do you think it was more the data, or do you think it was more the patient voice that had kind of the most power to try and get something up and running in Israel? Or do you think it was a combination of both? I'm just wondering, because of course across Europe there's a lot of us in the same situations that we're trying to get lung cancer screening on the agenda. So if you were able to maybe make a comment on that, that would be great.
Yeah, so and I just, because it was very interesting what you asked the question before about psychology, I wanted to say something about that also. Just a small sentence. I mean, I'm sure that in any country like in Israel, let's say you have in the system, you know, or in the oncology department or the institute, you will have a psychologist, a social worker. But I think maybe that even the physicians themselves don't refer enough the patients and the families for this, right? Okay, so I see we have 2 minutes. So I think it's a combination regarding the screening, because look, in the first 2-3 years in Israel, the excuse was, we want to see what Europe will do. Okay, we want to see what the results of the Nelson study will be. That was the excuse. But once the results came, and they were still skeptical and still also saying, why hasn't Europe started? Why should we start? You know, and I'm saying, well, it's in the US. And so I think, look, I think it's because it's such there was a problem with the science, okay? But because it's something which is a technology, it's not a drug, and there's no pharma behind it, no big money, no lobbyists, you know, etc. So it's really you need to fight for it, yes. And the truth is that all the disciplines, you know, because it's a multidisciplinary thing, I think they're too busy doing their own stuff, you know, to come and decide that that screening is their big, fight and problem. So this is our I think that the patient organizations can do it, because we know, you know, no matter what physician, but we know, we have it at home. We know what lung cancer is, you know, and we want to save every life because we know how difficult it is. This is our drive.
Yeah. Absolutely, Shani. And I think you make such a great point that we really all have to work together, and all of the patient communities have to come together to work for this. So I know there has been another question or two, but unfortunately, in the interest of time, we are just not going to be able to get to those. And I know this discussion, we could continue to keep going. Yeah. So I will bring the session to a close. I just want to thank everybody for their excellent talks, and to all the speakers for their time and energy. LuCE would like to thank ELCC and all of the organisers for the opportunity to have this session here today. And just make sure and catch up on the platform system to any of the talks you might have missed a little bit in. And I'm sure we can continue this conversation at our next meeting, and of course through social media and all of the various platforms as well. And I'd also like to thank my co-chair, Elena, as well. So thank you all so very, very much for taking part in this session today.
Thank you for having us.
Yes, thank you.
Thank you. Thank you.
Thank you.